Welcome to tonight's call. I am excited to discuss magnesium and its role in neurologic disorders tonight. Neurologic disorders ranging from anxiety to depression to schizophrenia to head injury, concussion, Parkinson's, Alzheimer's, Lou Gehrig's disease, stroke, all can be positively impacted by magnesium therapy, and all can be exacerbated by magnesium deficiency. And there's no shortage of neurologic disorders in our society. And as you'll learn tonight, there's also no shortage of magnesium deficiency. And so instead of using medications, or in addition to using medications for those conditions, which have side effects and adverse effects, we can also use magnesium, if the research supports it, to help us control symptoms and decrease tissue damage in those disorders. So that's what I want to talk about tonight. And the underlying physiology behind those disorders oftentimes is something called neuroexcitotoxicity. And in my best-selling book, The Autoimmune Answer, in chapter 1 on Parkinson's disease, I discuss excitotoxicity. I discuss the NMDA receptor, and I even point you to a video that I have made previously on YouTube about excitotoxicity. And I would point you that way if you'd like to see me draw out the pathway. If you'd like to see the research of it, then tonight's video will show you graphics of that. Let's dive into that research. This study is from 2018 in the journal Nutrients, and it's entitled The Role of Magnesium in Neurological Disorders. And I've also used contributions from a 2008 study on the NMDA receptor, as well as a great book by friend and colleague, Dr. Alex Vasquez, called Pain Revolution for Migraine and Fibromyalgia, where he also discusses the NMDA receptor, magnesium, and various topics. So one thing to know is that magnesium is well known for its diverse actions within the human body and is a necessary cofactor for over 300 enzymatic reactions in the body. Enzymes are proteins that do work. So if we're trying to heal, if we're trying to create energy, if we're trying to methylate something, no matter what our goal is physiologically, there's often an enzyme involved to help us accomplish that goal. And all enzymes have nutrient cofactors that they require in order to work. So magnesium is one of those cofactors in 300 different enzymatic processes. So if you are deficient in magnesium, then there's the potential for 300 different enzymatic processes in your body to be anywhere from suboptimal to deficient, which is going to lead to poor physiology and likely poor quality of life. Obviously, we want to be sufficient in magnesium. How prevalent is a magnesium deficiency? Well, this study says up to 50% of the US population is consuming inadequate amounts of magnesium. I've seen numbers as high as 87% of the US population is inadequate or deficient in magnesium. So that could contribute to obvious problems relevant to tonight's call from a neurologic standpoint, but it also could contribute to hypertension, could contribute to muscle contraction issues like trigger points, spasms, could contribute to vascular issues like migraine, which is also a neurologic issue, hypertension we already mentioned, stroke. So magnesium is very, very critical for our health. And this study states that, low magnesium levels may theoretically potentiate glutamate neurotransmission, leading to a supportive environment for excitotoxicity, which can lead to oxidative stress and neuronal cell death. Oxidative stress, we've talked about before, the metaphor for that is rust, right? If you leave a steel bumper outside, it's going to rust over time via the process called oxidation. So oxidative stress, you could picture your body rusting or aging too quickly. And then neuronal cell death is death of brain cells, death of central nervous system cells. If you kill brain cells, you have brain disorders. Makes pretty good sense. So here's the graphic we want to learn, and that's relevant for tonight's call. This is what's called the NMDA receptor. And if you're wondering what that is, it's the N-methyl D-aspartate receptor. And this receptor is triggered by glutamate. And glutamate, let me get my pen for you here. Glutamate is our body's excitatory neurotransmitter. So glutamate, you could picture as the gas pedal in our brain. We've all probably heard of something called monosodium glutamate, or MSG. That is glutamate that is added to our food by food manufacturers to trick the brain into thinking the food tastes better than it does. Therefore, we like it more and we buy more. So it's a nifty little trick to leverage, physiology and neurotransmission to sell more product. Glutamate, like I said, is excitatory. It's our main gas pedal. But if you overexcite neurons, you can kill them. Now, what's interesting is we were created to get our brake pedal from our gas pedal. Our brake pedal is called GABA. And GABA is our natural Xanax. Okay, this is our natural anti-anxiety neurotransmitter, and it comes from glutamate. So glutamate is converted to GABA by an enzyme called GAD65. So if we think about anxiety, right? Many people in our society have anxiety. And Xanax is a benzodiazepine medication that is given to people with anxiety very often because if you stimulate, benzodiazepines stimulate the GABA receptor. So it stimulates the natural anti-anxiety neurotransmitter in our head. Well, if we can efficiently convert the gas pedal glutamate to the brake pedal GABA, we can do that in a non-pharmaceutical way. But in order for that to happen, GAD65 enzyme must work efficiently. And as I said a few minutes ago, every enzyme requires nutrient cofactors to work. Relevant to GAD65, it requires iron, vitamin B6, and magnesium. So you can see the topic of tonight's call is magnesium. So let's say you're one of the 50 to 87% of people in the US who's got inadequate magnesium levels. Well, because that's a required nutrient for this process to go forward, if we're lacking it, then we can have a log jam here. We get less GABA, so we're more anxious, and we get more glutamate, so we're more anxious, and maybe promoting excitotoxicity further, destroying more neurons, driving more brain inflammation, promoting more neurologic disorder. So relevant to the GAD65 anxiety picture, we definitely want to have sufficient magnesium as well as B6 and iron. Well, the NMDA receptor requires magnesium to work properly. And it also requires magnesium. Part of working properly means adequate stimulation of this receptor. We don't want no stimulation of this receptor because this receptor allows for normal nervous system neuron function to occur. So normal thinking, normal speaking, normal movement, right? All the different things that we do as humans. So we want to have adequate amounts of glutamate stimulation of this receptor and then adequate amounts of magnesium to oppose it. Magnesium, you can see, fits in this as a block here, right in the central channel of this receptor. And I'll just orient you to the picture. The top of the picture is the extracellular fluid, or the outside of the neuron or brain cell. The bottom of the picture is the intracellular fluid, or the inside of the neuron. So as you can see, the calcium and the sodium at the top here is going to, when it's let in, enter through the NMDA receptor. And once you have calcium influx into a cell, the cell does its job, whatever that job is. So in this case, the neuron does its job. It transmits whatever signal is being conducted, and you have a thought, or you have a movement, or you have some physiologic outcome. Now, once glutamate binds this site and it opens the pore, and that happens, it closes back up. Now, if you're magnesium deficient, we may not close that channel as efficiently as necessary, and now we have more calcium entering the cell than is optimal, than is physiologic, than is wanted, and that leads to excitotoxicity, or overstimulation of this neuron, which can lead to death of that neuron. And like we said before, we don't want neurons to die, because those are brain cells, and also they don't regenerate well. We have nervous system stem cells, but not a lot of them. And so nervous system regeneration is very hard to do. We want to keep what we have. So how do we prevent neuroexcitotoxicity, and therefore symptoms of anxiety, depression, migraine, worsening of Parkinson's, Alzheimer's, all of those things? Well, we want to have optimal magnesium levels. And what's interesting is, if you've ever taken a magnesium supplement, you might say, well, what magnesium do I need? There's a million kinds. There's magnesium oxide, malate, citrate, succinate, glycinate, all kinds of different eights. If you look on your magnesium supplement, on the back in parentheses, it'll say magnesium as magnesium succinate, or magnesium oxide, or magnesium glycinate. Well, the 8 word is what the magnesium is paired with. So interestingly, if we want to stop or plug this NMDA receptor with magnesium, the most efficient form is going to be magnesium glycinate, because the magnesium will plug the pore here, and the glycine, which is glycinate, it's an amino acid that fits right in here and helps oppose the glutamate stimulation of this. So magnesium glycinate is a supplement that could be very useful in anxiety, depression, Parkinson's, Alzheimer's, stroke, those sorts of things, those sorts of conditions. Also beneficial can be zinc, because zinc plays a role in this receptor function. So zinc, magnesium, glycinate all play a role in neuroexcitotoxicity, or modulating NMDA receptor function, so that we don't spin out into neuroexcitotoxicity. So I drew that GAD and GABA picture for you. Well, on the nerve cell membrane, you have lots of receptors. This NMDA receptor is just one. Somewhere else down the membrane here, we also have a GABA receptor. And we just talked about how glutamate is converted to GABA, and GABA is a natural anti-anxiety neurotransmitter. Well, GABA receptors are neuroinhibitory, right? Glutamate is the gas pedal, GABA is the brake pedal. So we can use magnesium to plug the NMDA receptor, and then we could also seek to stimulate the GABA receptor so that we inhibit this mechanism through a second way. Okay, we stop it right here in the central core, and then we stimulate this receptor to inhibit that receptor. So stimulating the GABA receptor, we can leverage things such as niacinamide, which is a form of vitamin B3. We can use alcohol, right? Alcohol probably isn't the best choice, but alcohol works because it's similar to benzodiazepines, like Xanax. Okay, and that's how sometimes benzodiazepines mixed with alcohol addiction are not a good choice. And there's various botanicals that you can use to stimulate the GABA receptor, such as passion flower and valerian and various others. So by stimulating this receptor, we can also hit the brakes, also decrease neuroexcitotoxicity, help with anxiety, depression, and various other things. One of those other things is decreasing pain. So it's important to know that there's NMDA receptors throughout the nervous system, in the brain and spinal cord, but also on peripheral nerves. So you can, like I said earlier, you can have anxiety, depression, those big scary diagnoses like Parkinson's and Alzheimer's, but maybe your problem's none of those. Maybe it's migraine or seizure, or maybe it's pain, or maybe it's trigger points, fibromyalgia, like peripheral pain. Well, this receptor, and therefore magnesium and GABA, are important for all of those things. So it's important, if you're suffering from any of those issues, to understand what your magnesium levels are, so that if your magnesium is too low, you can raise it up. And in your case, that might be a simple and inexpensive way to improve your quality of life and get you closer towards an asymptomatic presentation. So let's open it up for questions.
I have a question.
Okay.
I asked before about taking magnesium, you know, when we started all the stuff that you gave me.
Yeah.
I used to have terrible migraines, and 12 years ago, I started taking magnesium glycinate, and I have not had a migraine since then. But I'm terrified that I've stopped taking it, that I'm going to start having my headaches again. So that absolutely worked for me.
Good. Thank you for sharing. So I think your question is, why are you not taking it right now?
Yes.
Why did I tell you to not take it?
Yes.
Okay. Can I share personal information about you?
Sure.
All right. So we tested your magnesium, and your magnesium was in sufficient range. So if you push it too far up, you can have issues with too much, right? Just going back to that seesaw,
Right.
that we always talk about. Too much or too little is bad. We want to be in between. So you had sufficient magnesium levels, so I wanted to scale back and work on other things. And we'll look at your magnesium again in the future and bring that back in as necessary. Or, you know, if you had symptoms before we got to a retest, then we might want to consider adding it back empirically. But with the actual data we have on you, it was fine. So, you know, in considering the number of things you had to swallow, it was like, okay, well, right now she doesn't necessarily need that.
Okay.
Make sense?
Yeah.
Cool. What else?
This was fantastic because our first functional medicine doctor put us both on magnesium glycinate, but never explained it like this. And it's like, oh yeah, that makes so much sense. Because we were both, she had tested us both for, adrenal fatigue.
Oh gosh.
I know. And so she'd also put us on Serenigan. And she'd put us on Serenigan, which was like natural anti-anxiety sort of stuff. I mean, neither of us were like crippled by panic attacks or anything like that, but she just thought it would help. And then we were also on magnesium glycinate. So this makes sense. I can't tell you what my magnesium levels either of us were, but this was never explained to this level. So thank you very much.
You're welcome. And relevant to your case, right? We can share about you, right?
Yeah.
Okay. So in multiple sclerosis, obviously there's neuroinflammation and neuron death and white matter lesions. You know, there's obvious evidence on MRI of that. So if the neuroexcitotoxicity picture is at play in your case, and magnesium insufficiency to deficiency is there, then this could be a huge, again, an inexpensive thing to use to contribute to the slowing of that process and the improvement of symptoms. Yeah. So yes, you know, the cool thing is if you take the right thing for the wrong reasons, or you don't even know why you're taking it, it can still help. But as we, you know, the more we learn and understand it, the more we can intentionally do things as best we can.
Right.
So yeah, it's
huge.
It is. And
you didn't put me on it, so I think I tested okay for it.
Yeah.
it's just interesting to know the mechanics behind it. That's important. So,
I think so. At least for the doctor, you know,
yeah.
I think so for the patient too, just so you know why we're doing what we're doing. And, you know, you're not like, oh, of course he's going to tell me to take this supplement forever because he wants to get paid this month. You know, there should be a reason beyond that as to why you're on something.
Right.
And one thing for you all to further understand, and anyone else who's watching this, you know, much later in the video's life, is that there's a couple ways to test magnesium. So there's serum magnesium, which is the most common way that they test it, and because it's inexpensive, but that's crappy. And there's red blood cell magnesium. And so the red blood cell magnesium is a better indicator of what your levels are. It's a little bit more expensive test, but it actually is helpful for us. Serum magnesium, you can be insufficient without the number moving much. So it could look good in the blood, but not be good, you know, in the system. So red blood cell magnesium is a better marker for us to follow and track you. What other questions?
You were saying that calcium and sodium feed the magnesium. Is that correct?
Calcium and sodium enter the cell when
Enter the cell.
when glutamate binds and the magnesium moves out of the way, or you could picture like that it's spreading apart, right? So creating a channel down this way.
And so if you're on a vegan diet or something that doesn't have a lot of, I don't know, I guess I'm wondering how much calcium and sodium would enter, or that you would need to be healthy to enter, because, you know, lots of people say, oh, stay away from all the salt and all the calcium, I mean the dairy and stuff like that. So I'm wondering how much calcium and sodium is needed for that.
Well, if your physiologic levels of calcium and sodium are okay, then you're probably okay. Are you asking how much calcium should you consume?
I'm just wondering, like, I don't even know if that was a question or not. It just hit me. It just struck me that calcium and sodium together are entering this. And so I'm just thinking about when we first started, and, you know, I had all these questions about, you know, the ancestral diet and things like that. It's like, where does the protein, where does the calcium come from? Should I use salt, not use salt? And then your body needs the calcium and the sodium, and it's just amazing how it's just so interconnected, and everything that you teach us weekly, it's amazing how it all works together. And if one little thing is off, then it could, I mean, you said like it was like 300 cofactors or something.
Yeah.
It's like, that's a lot of cofactors.
Yeah, and that's why, you know, oftentimes you'll have an issue, a person will have an issue, and a medication won't solve it, right? Because a medication is researched and studied to, diseases are in a conventional medical model are studied to say, okay, what pathway has gone wrong to say cause this disease, right? So in Parkinson's disease, you know, there's issues with dopamine production, right? So, well, then let's make a drug to give them dopamine. Let's give them levodopa. But there's lots of, you know, that drug might give you a dopamine hit and give that person help for 3 or 4 hours, but then they need to take another dose of it, you know, every 4 hours they're taking levodopa. And in my book, I talk about how, well, that drug has been shown to raise homocysteine levels, which is a great way to drive NMDA receptor activation and speed the Parkinson's process. Or maybe it doesn't do it in an individual person, but that person's Parkinson's was driven by a gut infection that traveled up the vagus nerve into the brain and drove Parkinson's. Well, giving them levodopa never, you know, that neurologist maybe never even looked at or considered their gut. So the process that's driving the disease stays there, but oh good, they're on levodopa, right? We did standard of care, right? So yes, looking at it, I'm biased, of course, but looking at it from a holistic view helps us find the sticks and the spokes instead of duct taping over the victim's mouth, right? Just combined a couple metaphors there, but yeah. So I think to maybe help you with your question, if it was one, is calcium and sodium are necessary, right? We don't want no calcium, no sodium. It's more about if we have too much calcium influx because of too much glutamate, then that drives an excited cell, and excited cells die. Make sense?
Yep.
So we're not trying to, in this case, we're not trying to avoid calcium and sodium. We want to affect glutamate and magnesium and glycine. So we leverage this by impacting receptor response rather than electrolytes. Unrelated but related is sodium has been shown to drive autoimmunity by increasing Th17 cells in the immune system. Those are the cells that drive autoimmune tissue damage. So that would be one reason why we would say, hey, Karen, if you're an autoimmune case, you don't want to be salting your food and adding extra sodium if your levels are sufficient, because that sodium could exacerbate your autoimmune process. And if that autoimmune
happened to me.
Yeah, I was going to say if that and I didn't even know you were going to say that and didn't know it just happened to you, but I was going to say, and if you happen to have MS, that would exacerbate, say, the neurologic symptoms or Parkinson's or whatever.
Yeah.
But isn't there a difference between like table salt and real salt, like unrefined sea salt?
No.
Or not in the...
No, sodium. Yeah, whether it's white or pink and blessed by a shaman, it's all sodium.
I guess I won't be salting the eggs in the morning.
Well,
I salt my eggs. But what I did was I accidentally used too much in the recipe, and I had less Brussels sprouts than the recipe called for, and put them in the air fryer, and they were super salty. I ate some anyway, and I noticed for sure by that night, and I noticed the next day. And it's so fantastic to notice these things.
Yeah.
I mean, I don't want to, but I'm like, what is going on with me? And I was like, oh, I had excess salt today, and I could pinpoint that.
That's the proud papa moment.
Yeah.
Like our, with everyone, I tell you, when we're sitting down, right, we want to get to Dixie cups, and Jennifer's reached Dixie cups. And so part of the Dixie cup part is, hey, spread your wings, keep doing what got you here. And part of that conversation is when we first sat down, I told you, I don't want you to be a dependent patient for life on me, right? I want to empower you with the ability to spread your wings and go. Well, part of that is when you spread your wings and you notice symptoms, it's not call me, it's take a self-inventory. Oh, what's changed? So Jennifer just nailed that. Oh, I had more salt to Brussels sprout, her salt to Brussels sprout ratio was high salt. But just to have that ability to do the self-inventory and find it without me, and that's awesome, because that allows you to, be a mature life at optimal adult.
And it just reminded me of your salt video, and I already know I had Th17 issues. So it only made sense, and I was very grateful for that knowledge. So super careful now.
Awesome.
Well, I must have forgotten, or I don't know if we discussed it, but I will be cutting back on the salt. And like Janelle just said, I use real salt, and I was thinking, oh, I'm getting extra mineral.
Yeah.
Yep.
Well, Karen, I just looked at your numbers, and we have multiple tests on you. Your sodium's fine. So you don't necessarily have to cut back unless you're noticing symptoms. Like your sodium's optimal to the level that you have space before you would be flaring it. So unless Jennifer, even if her her sodiums are optimal range too, but she's got a disease process that can be driven by it, right? So if you don't have a frank autoimmune disorder where, you know, a Th17 process is involved, then you're probably okay to salt your food. Whereas Jennifer, you know, maybe isn't okay to salt it as much as she did, or, you know, needs more Brussels sprouts for that amount of salt. Make sense, Karen?
Yes.
I don't want you to walk around like fearful of salt in your case. Cool.
Yep. Cool.
What else?
So
Oh, go ahead.
hypothetically speaking, I'm pretty sure my magnesium levels are totally fine when we went over, you know, testing that. But obviously, when you speak of like taking magnesium glycinate, it helping anxiety, depression,
Yep.
it's like that sounds like the elixir of gold to me. So I kind of want to go chug a full bottle of that. Hypothetically, if I did that, what would happen?
A whole bottle?
Well, I mean, I'm being a little dramatic here, but yeah, what if
Yeah, yeah.
Like, could I take a very small dose of that, even though my magnesium levels are fine?
Sure. You could experiment with it. You know, your level is optimal. You're far from being too high. So if you know, and again, we want to remember that we need it every day. We're metabolizing through it. 300 enzymatic processes every moment of every day are going on, or a large majority of those. So you're using magnesium. So we need magnesium, but if you trust the recommended daily allowance, you only need 400 milligrams per day. You know, so Patterson, your levels are good, but you're continuing to live. So if you were, you know, we're providing you 400 milligrams per day just in the multivitamin, but if you're metabolizing through that faster, then adding a little bit more may be useful. So
I didn't realize that was the glycinate in the multivitamin?
I don't believe it's the glycinate form. I think it's succinate, but I'd have to.
Hold on, I'll look.
Yes, thank you.
There you go.
I just got a shipment. So it is citrate, and it says citrate, oxide, but it's magnesium citrate.
Citrate.
200 milligrams in the 6 capsules.
Oh, my bad. So it's half of what you need. So 200 in 6 capsules. So yeah, you could grab, Patterson, you could pick up a glycinate and add that and see if it impacts the anxiety.
Hell yeah.
What brands do you recommend?
Of magnesium?
Yeah.
I mean, it doesn't, I don't think the brand matters as much as long as it's magnesium glycinate, because biochemically, you know, it should be what it is regardless of the brand, unless they're adding, you know, sweeteners or some garbage excess ingredients to it. But magnesium glycinate should be magnesium glycinate wherever you're getting it.
Okay, because I read that it's like hard to absorb sometimes, and that I think maybe some people even use like magnesium oil or something, or spray it on pass through the skin.
Yep, or liquids and do foot baths with it. Yeah, there's different ways. There's different ways to do it. I forget what the company was called. Maybe Ancient Minerals. I used to get magnesium oil, which is basically magnesium water, from this. I think they were called Ancient Minerals. And
Yes, they are.
Okay, I used to get that and do the foot baths, or I'd lay down after a shower and pour it on me and rub it in and all that. So yeah, you can go to that level with it if you think you're not absorbing. So oftentimes there's been research in diabetics, specifically type 2 diabetics, that magnesium foot baths are helpful in getting magnesium into the body. And magnesium's needed for blood sugar regulation and insulin sensitivity. So, you know, type 2 diabetics, that could be helpful. And, you know, essentially anybody if we're absorbing it that way. It's just hard. I don't know how much you're getting when you do that. Like a capsule, I know, here's what I threw down. the putting it on the skin is like, okay, I got some. I don't know how much that was.
But you've seen that people have absorbed it well when you've retested and stuff by taking it orally.
Yeah. I actually had a patient recently where I had to tell her at her 6-week test to stop because she was lab high. So it had taken her too high, which is fine. That's why we retest is to see how we're trending. So it's like, okay, set that on the shelf. We can leave that for now. At the 12-week retest, we'll see it again, see where you're at, see if it's necessary at that point. But that's a good problem anyway. Cool. You're not even close to deficient.
I was going to ask you about that. We're all working our own protocols and everything, and we've got the week countdowns and things like that.
Mhm.
Would you rather us, because I guess some in the group are at the Dixie Cup level and they're maintaining what after 12 weeks and stuff, and some of us are in the middle and some of us are just starting out. So would you prefer that we just stay the course with what we have worked out until we start adding all this other stuff? Because I was just thinking of, with my trouble sleeping and with anxiety and stuff, that, I'm like Patterson. I'm like, show me the give me the bottle, just, intravenous. And so I just don't know if I should, delve into that and just wait for the 12 weeks and then we can do another test and see where I need to go.
Yeah. So can I share information about you?
Sure.
Okay. Your level was optimal. So remember, magnesium deficiency or insufficiency isn't the only cause in the world of anxiety. Okay. So in your case, it seems unlikely that that's a driver. Okay. You have optimal magnesium levels. If you didn't, maybe your anxiety would be worse, but that's not the driver in your case.